All right, good afternoon, everyone, or good morning, depending on where you are. Again, I am Cheryl Barnes. I'm a nurse practitioner here at Memorial Sloan Kettering Cancer Center in New York. That's in the northeast section of the US, and I'm happy to be able to share this presentation with everyone today. My presentation is a little shorter today as I am only speaking on tumor lysis. Again, I am happy to be here, and I hope this will be a great presentation for everyone, and you'll have some takeaway from it. So without any ado, let me start off with the presentation. So I'm going to be talking about tumor lysis syndrome. So what is tumor lysis syndrome? This is basically a metabolic imbalance that occurs when there's a rapid release of intracellular potassium, phosphorus, and nucleic acid into the blood as a result of rapid tumor cells. We talk about oncology emergencies. This is definitely an oncology emergency. It is potentially life-threatening, and therefore is something that we have to be aware of for all oncology patients. So what are the risk factors? So patients with tumors that have a high growth fraction, individuals with bulky disease, and tumors that are associated with elevated LDH levels. Also, some other out of the tumor risk factors that may put patients at risk for having tumor lysis is if they have a history of renal disease. Advanced age is usually something that we think about. Thiazide diuretics, alcohol consumption, and levodopa. Those are things that can potentially put patients at risk for tumor lysis syndrome. What are the common tumor types that we see? So the leukemias, the lymphomas, and in the solid tumor, the bulky tumor, so the small cell lung cancer and breast tumors are likely to cause tumor lysis syndrome. So let's talk about the etiology, right? So there are two ways in which you can get tumor lysis. You can get it from the actual therapy, or you can just get it from the spontaneous tumor lysis syndrome of the tumor rapidly dividing cells. So we want tumors to actually respond to treatment and these cells to be rapidly killed. So this is almost like an oxymoron, like we want this to happen, but it also can be potentially life-threatening if it divides too rapidly. So any therapy that results in rapid cell kill, whether that is chemotherapy, radiation, or the glucocorticoid therapy, that would be the hormone therapy that causes the cell to rapidly divide, which is exactly, and kill, which is exactly what we want to get rid of the cancer, but it can also be potentially and have negative impact by causing tumor lysis syndrome. So what the pathophysiology is, as you can see, a living cell and a dying cell. So the rapid lysis of the cell or proliferation of the cell releases intracellular contents. So what it releases is potassium, phosphate, and nucleic acid into the systemic circulation. And that's what caused the problem. So what happens, you end up with a metabolic abnormalities that develop from the breakdown of the tumor cell and the kidney's inability to clear the cellular byproducts. So you have this breakdown of these cells rapidly, and then the kidneys are not able to excrete it. And so that's when you get the buildup, and that's when the problem really becomes a problem. So let's talk about the pathogenesis. So what do we see? With the hyperkalemia, increased potassium, you'll see the cardiac arrhythmias, the weakness, the paralysis. With the increased phosphate, you'll see edema, decreased urine output, or no urine output, or just acute renal failure. With the hyperuricemia, you'll have renal insufficiency, you'll have flank pain, and you can even have seizures. With the low calcium, the hypocalcemia, what happens, you can get muscle cramps, weakness, tingling in the hands and the feet. So when does tumor lysis happens? Some literature say as early as 12 hours, but normally the literature is saying that 24 to 72 hours, so a day to 3 days after the initiation of treatment. And that's the tumor lysis that occur from treatment. That's the treatment-related tumor lysis. It can, however, last up to 7 days. So don't feel that you're out of the woods if it's over 72 hours, because you can get it at a later time. And the goal is really to prevent renal failure and severe electrolyte imbalance. So what are the labs that we look at? We look at the LFTs, the liver function test, especially the LDH, which we want to be in a range of 12 to 246, the BUN and creatinine, the serum electrolytes, so the potassium, the phosphorus, the calcium, and the uric acid. And we want to see a urine pH of 4.6 to 7. One of the things that I always emphasize is the labs where you do these tests should be consistent, because every lab, even though these are like the normal range, labs vary depending on what instrument they use for collaboration. So you may see one be off by points. So it's important to be consistent where these labs are done. Resulted, because you might see a difference in result if it's done at different labs. Okay, so this is a very, if there's no takeaway from this talk, please take this away. This is a very, very important lab, because it would drive what can be given to patient. There are some patient who has G6PD deficiency, which is a type of hemolytic anemia that certain foods or medication can cause an increase in the rate of red blood cell breakdown, which could be life-threatening. So Rubicase, which is one of the medication I'll talk about later, is contraindicated for patients that are G6PD deficient. So it's important for every patient that there's a potential for tumor lysis, or if you're going to treat them for tumor lysis, you need to make sure that you do this G6PD, as it will impact what medication you can treat them with. So in treating the tumor lysis syndrome, one of the first and very, very important thing is hydration. Hyperuricemic agents such as allopurinol and rasburicase, which I will talk about, that's the one with the G6PD deficiency. That's the one that will be impacted if the patients have that deficiency. And you also need to alkalize the urine. So hydration. This is aggressive hydration prior and after treatment. And this is almost oxymoron what I'm saying, because I'm saying to hydrate them, give them fluid, but I'm also saying give them diuretics to prevent fluid overload. Especially those cardiac patients, you do not want them to get fluid overload, but you want them to be appropriately hydrated. You want to decrease the urate deposit in the kidney, and you want to increase urinary clearance of urate and phosphate. So you want to maintain a urine output of greater than 150 to 200 cc's per hour. So these patients are hydration and urine isonose and weight are very, very important. You need to keep track of what their hydration status is. So isonose and weight to make sure that these patients are not fluid overload, yet you want to make sure that they are hydrated. So it's a dance, it's a balance of how can we balance to make sure we hydrate them, but make sure we don't fluid overload them. And what are the hyperuricemic agents that we can give? Allopurinol, right? And so allopurinol ultimately decreases the uric acid production and formation. So you usually give this to prevent, so administer prophylactically, and the doses usually range 300 to 800 milligrams per day. The other hyperuricemic agent, which I talked about, is the rasburicase. This reduces the serum uric acid concentration. This is given both as a prevention and is also one of the agents that we use most often for treatment. And the IV dose is 0.2 milligrams per kilogram daily times 5 days. Serum uric acid levels are drawn within 24 hours post rubicase dose, and this must be sent to the lab in a pre-chill specimen tube. So everyone has to be aware that this is important how this is sent, because it's important to get the right reading. Again, the G6 PD should be drawn and resulted prior to anyone given this medication, because it is contraindicated if there's a G6 PD deficiency. It could be life-threatening if you do give the rubicase in this patient population. How do you alkalize the urine? The alkalization of the urine, that promotes solubility of the uric acid, and it minimizes the uric acid precipitation. And the way you do that is by giving sodium bicarb added to IV fluid to maintain a urine pH of 7. Pharmacological management. For the hyperphosphatemia, the increased phosphorus, we want those phosphorus binding aluminum antacid. Seblamar is one of the things that we use. For the hyperkalemia, what we do is the hypertonic glucose plus insulin. So you're going to give the hypertonic glucose, but you also have to follow it by insulin because their glucose level will be elevated. You can give Kexalate to get rid of the potassium via the intestine, and you can give loop diuretics to get rid of the potassium. So what are the clinical interventions? What do we need to know as clinicians? We have to be able to assess for and recognize patients that are high risk. We have to manage the outcome or the events that happen, the hypertension, the irregular pulse, the chest pain, the shortness of breath. And as you can see, this can be mimicked by anything. You could go into a cardiac dysrhythmia for something other than tumor lysis. So we have to make sure that we are in tune to, okay, this patient is likely in tumor lysis because of this, but these are not that's not the only reason why someone could go hypertensive or have an irregular heartbeat or chest pain. So we have to be mindful. This could be a cardiac arrest from something else. So we have to be mindful of all the differentials. Assess for renal insufficiency, so decreased urine output, altered mental status, weight gain, which would be from urinary retention likely. Review medication and rationale with patient. So for some of them, you have to make sure that we initiate seizure precaution. So if they have, that's one of the things that could happen with the tumor lysis. And we have to make sure that we monitor the lab and make sure that we keep people within the right electrolyte balance. And this is just a small synopsis of a case. So RS is a 45-year-old male admitted for initial treatment of stage 3 aggressive bulky non-Hodgkin's lymphoma. He's married, works full-time, and has 3 children. He expresses to you that he wants to receive the treatment that will work the fastest. He's admitted specifically because of his high tumor volume. He's at high risk for developing tumor lysis. And why? So essentially for the non-Hodgkin lymphoma, that's a bulky, that's a disease that has rapid cell proliferation. So patients are at high risk for tumor lysis syndrome. So that's one of the things that we have to look at. We have to look at patients that are high risk. We have to put in place things that will prevent or help to prevent the patient from developing these tumor lysis syndrome. So the allopurinol, we have to make sure that we hydrate these patients. We have to make sure that we, as I said, have a good balance between hydration and fluid overload. So these patients has to be monitored really carefully. Prevention in many cases are better than the intervention, right? So we want to make sure that we are prepared if this happens, we are able to treat these patients, but we also want to prevent this from happening. So as I said, this is a short presentation today, and that's the end of the presentation, but I am open to any questions. And these are the references.
Thank you so much, Cheryl. And then if anyone does have any questions, please feel free to add them to the Q&A. I know I'll give a couple of minutes here for people to add them as well. Again, some positive feedback in the chat, so thank you so much. And just as a reminder, this is part one of the presentation, and we'll be lucky to have Cheryl back with us in a couple of weeks to discuss febrile neutropenia as well as part two. So please feel free to add any questions. Let's see, let's see if we might have one. Okay, so we have our first question in the Q&A is asking, please explain more in the management. You said that you give more fluid to improve hydration and you give diuretics. Is it a challenge to the kidneys to prevent cardiac overload?
Could you read that again for me, Caitlin?
Yeah.
I'm trying to look at it. Is it in the chat?
It is. It's in the Q&A. Are you able to see that at the bottom of your screen?
Yes. Yes.
Okay. Yeah, it might be easier.
Explain more in the management. You said to give more fluid to improve hydration and give it diuretics. Is it a challenge in the orange print cardiac? That's an excellent question, because that's probably one of the most delicate balance, and it's both. We want to make sure that the kidney is able to excrete. We don't want to, for some patients, we want to make sure, like if you have any renal insufficiency or your kidney is compromised in any way, it will be harder for the kidneys to really get rid of the fluid. So we want to make sure that patients are able to excrete it. And we also want to be mindful of the other system. Just because it's being excreted through the kidney, it doesn't mean that your other systems are not impacted. So your cardiac system is one that we have to make sure, and your lung, we have to make sure that we do not get pulmonary edema and we do not get cardiac edema. We want to make sure that those systems are also protected. So while we want to give the fluid, we want to make sure that we have a good balance of fluid intake and fluid output. So we want to make sure, as I said, the isonose are very, very important. Every hour, these patients has to be monitored. So you can't just wait until the end of the day, you do a one-time INO. You have to constantly monitor them per hour. And if you see like hour 2 that they're not making that 150 to 200, it's important that you intervene immediately. You can't wait until at the end of your shift, you look and you see that it's in the first hour, second hour, they did not make that urine output, because then it's too late, because you could have caused some damage. So strict isonose are very, very important for these patients. And yes, both cardiac and for the renal, you want to make sure that these are all addressed.
Thank you so much. And then
how do we prevent seizures? Well, we can do anti-seizure medications, and not all patients will get seizures. So we have to make sure that we are very much on top of the labs and see what's happening with the lab. So if the labs are off in the manner that we think that this would likely cause seizure, we can give anti-seizure medication as a precautionary measure.
Thank you. And maybe we'll just give a moment or so here to see if there's any more questions that come into the Q&A. But while those are being typed, I just want to also give a brief reminder that our next lecture will not be until Saturday, March 25th. So there'll be a couple of week break before our 6th lecture in the series. But you'll be receiving an email from me later this week, and also some reminders from Zoom about that schedule as well. But so we will have two off weeks before our next lecture.
And just to remind everyone, the thing that causes the seizure is usually the uric acid, the increased uric acid. So if you see that, then you're going to be alert that you have to be aware that these patients can have seizures. And these are the patients that you likely think to prophylactically prevent seizures. And the other seizures precaution is just like making sure that they're in a place that if they do have a seizure, that they'll not have, that they'll not hurt themselves. So make sure that if they're in a room, that they're things away from the bed that they could hurt themselves if they have a seizure and fall, that you know, that the side rails are like covered and stuff like that, so that you want to make sure that if they do get a seizure, that they do not hurt themselves by hitting something hard. And naturally things like falls precaution to make sure that, you know, that there are no, you know, the floor is not wet, like there are not obstacles and stuff like that, that they could fall.